Hello all, welcome back to my channel Connect Radiology, and today we are going to discuss about Ductus Venosus Doppler. Okay, so let's start with the fetal circulation first. Okay, so fetal circulation differs from adult circulation because we adults have lungs for oxygenation. Okay, but the fetus lungs is not functional, instead it has placenta for oxygenation. Okay, so that's the main difference, lungs versus placenta. So fetal circulation has presence of certain vessels and shunts, okay, and these shunts close after birth, okay, and most of the fetal vessels are visible as remnants in the adult circulation. Okay, so why these shunts are there? The function of these shunts is to direct the oxygen rich venous blood to the systemic circulation and to ensure that oxygen deplete venous blood bypasses the underdeveloped pulmonary circulation. Okay, so what extra fetus has? These have ductus venosus, foramen ovale and ductus arteriosus. Okay, so we will see the fetal circulation here. So what happens that this is the internal iliac artery and then the umbilical artery. Okay, these umbilical artery goes to the placenta, taking the deoxygenated blood from the whole of the body to the placenta. Then this placenta, like, oxygenation happens here, and now the oxygenated blood is carried from the placenta towards the fetus via the umbilical vein, okay, through this and at the site of attachment of the umbilical cord at the umbilicus. So this umbilical vein carries the oxygenated blood in the fetus. Okay, now the oxygenated blood through this umbilical vein reaches to the fetal liver. Okay, within the fetal liver there is this ductus venosus. Okay, what does this ductus venosus do? So ductus venosus connects the umbilical vein directly to the IVC. Okay, so the oxygenated blood which is like passing through this umbilical vein goes to the ductus venosus to the IVC. Okay, and then from the IVC to the right atria. Okay, but the anatomy of this ductus venosus is such, okay, it is like trumpet shaped. It has a sphincteric action, okay, and the diameter is narrow, so the velocity increases. So what ductus venosus does is it gives a passage for the oxygenated blood towards the IVC and right atria, and also because of the high velocity the blood goes from the right atria to the left atria via this foramen ovale. Okay, this oxygenated blood gets directly to the left atria through the foramen ovale, and now from left atria to left ventricle, and then from the left ventricle oxygenated blood goes to the fetal brain and myocardium. These two require highly oxygenated blood for their functioning. So this ductus venosus main action is to like shunt the highly oxygenated blood from the right atria, like from the umbilical vein to the IVC, and then from IVC to right atria to foramen ovale to left atria, and then to the brain and myocardium. Okay, also this umbilical vein also supplies some blood to the liver, and from liver portal veins to hepatic veins to IVC. This blood also goes to the right atria, okay, then to the right ventricle, and from the right ventricle to the pulmonary arteries. Okay, but within the fetus this pulmonary circulation is not well developed. Okay, so what happens is this, there is this ductus arteriosus which like takes the blood from the pulmonary artery to the aorta, okay, for supply of rest of the fetus. Okay, so same thing what I have said now is like here. So what's the pathway for oxygenated blood? So lungs finish their development after birth. Before this, lungs function is taken over by the placenta, which is oxygen transfer organ during the fetal life. So oxygen rich blood is carried by the umbilical vein from the placenta to the fetus. Okay, now this umbilical vein enters at the umbilicus and reaches the anteroinferior portion of the liver to finally drain in the portal sinus. The ductus venosus connects the portal sinus with the confluence of the hepatic veins into the IVC, or I can say ductus venosus connects the umbilical vein directly to the IVC. Appropriate channeling of blood flow is required to ensure sufficient oxygen and nutrient supply to the vital organs, and this is achieved by unique features of the blood vessels which help create difference in velocities and direction of blood flow. And that here comes the role of ductus venosus. Its diameter is 1/3 of the diameter of umbilical vein. Okay, so the blood is shunted to the IVC under pressure. This increased pressure propels the blood in the IVC to the right atria and directly into the left atria via foramen ovale, and then this blood passes into the systemic circulation by the left ventricle and the aorta. This is the pathway for the oxygenated blood. Now what happens to the deoxygenated blood? So the carbon dioxide rich blood from the brain and the upper extremities returns to the right atria via the superior vena cava, and then this blood passes into the right ventricle to the descending aorta, okay, via this ductus arteriosus. This occurs because the lungs are not well developed and pulmonary arteries offer high resistance to the blood flow. At the same time, blood from hepatic circulation and lower extremities return via the inferior vena cava to the heart again, and it passes into the descending aorta through the path of the right ventricle, pulmonary artery and ductus arteriosus, and finally to the descending aorta. Okay, and now all these blood passes into the circulation carried by the umbilical arteries back to the placenta for oxygenation, but there is small amount of blood that gets filtered by the lungs also and reaches the left atria via the pulmonary veins. So this is how the fetal circulation works. Okay, so this is how the fetal circulation works. The role of the ductus venosus, then the foramen ovale and the ductus arteriosus. We have discussed all that. Okay, so here you can see that this is the umbilical artery. Okay, this is the umbilical vein, this is the IVC, and the arrow here is the ductus venosus, and this is the descending aorta. Okay, so in the part 2 of this video, I will show you like how to localize ductus venosus, okay, while doing the Doppler. So all these things we have discussed, the role of the ductus arteriosus, then the role of the foramen ovale and the ductus venosus, foramen ovale and ductus arteriosus we have discussed. Again the same thing, the fetoplacental circulation, oxygenated blood, deoxygenated blood, role of placenta, role of ductus venosus, foramen ovale and ductus arteriosus. Okay. So when placental resistance increases, okay, the abnormal pressure produces increased afterload which can impair right ventricular function. The right ventricle accounts for more than 50% of the cardiac output in the fetus. Thus, any process that has a negative effect on right ventricular function adversely influences the fetal well-being. Okay. So, this video is about ductus venosus Doppler. Okay. So, in the first trimester, the focus of Doppler is like for detection of aneuploidy and for congenital heart diseases. Okay, now this aneuploidy detection and congenital heart diseases, which Doppler? Ductus venosus Doppler is done, and also to screen the women for preeclampsia by evaluation of the uterine artery. So first trimester, which Dopplers are important? uterine artery Doppler and ductus venosus Doppler. Uterine artery for preeclampsia and the ductus venosus Doppler for aneuploidy and congenital heart diseases. In the second and third trimester, the detection of IUGR is very important. Okay, and for this Dopplers are important: umbilical artery, middle cerebral artery, umbilical vein, ductus venosus. Okay, and for preeclampsia, it's again the uterine artery, and for fetal anemia, measurement of peak systolic velocity in MCA Doppler is important. Okay, so first trimester ductus venosus Doppler and uterine artery Doppler, and second third trimester ductus like for the growth restriction, Doppler of umbilical artery, MCA, umbilical vein, ductus venosus, and for anemia, MCA as well as ductus venosus Doppler comes into role, and for preeclampsia it's uterine artery. Okay, so now let's see the Doppler for ductus venosus. Okay, so we all know ductus venosus is a trumpet shaped connection that connects the umbilical vein with the IVC directly, and that shunts the blood like helps in shunting the blood from the left atria to the right atria to the left atria through the foramen ovale because of the high velocity and the pressure. So ductus venosus role in first trimester is to screen for aneuploidy and congenital heart disease. Okay, and in the second and third trimester it is used to assess the cardiac strain and this cardiac strain can happen in various scenarios like IUGR, like Rh negative pregnancies, like anemia, like twin to twin transfusion syndromes. So this cardiac strain assessment is done by this ductus venosus Doppler. Okay, so how this ductus venosus Doppler is done? So I have already said ductus venosus Doppler in first trimester for aneuploidy and congenital heart diseases, and second trimester IUGR and fetal cardiac compromise. Okay, so ductus venosus Doppler should not be done during fetal movements. The fetus should lie still. The magnification should be such that only the fetal thorax and abdomen occupy the whole image. Okay, right ventral mid sagittal view of the fetal trunk should be acquired. Okay, and ductus venosus will show typical aliasing. You have to like take the spectral Doppler at that aliasing with a small sample 0.5 to 1 mm gauge and an insonation angle of less than 30 degrees and a high sweep speed. Okay, this is how you do the ductus venosus Doppler. The fetus should be still. Okay, the probe is ideally focused. Sampling is done where the umbilical vein joins the ductus venosus. Right ventral mid sagittal view of the fetal trunk is taken. Aliasing point of aliasing is noted, and there we like take the spectral Doppler. The sample should be small, 0.5 to 1 mm. Insonation angle should be like less than equal to 30 degrees. The sweep speed should be high, and the image should be magnified enough for the fetal thorax and abdomen to occupy the whole screen. Okay, the normal wave pattern of ductus venosus is a triphasic waveform pattern. Normal physiological situation, the flow should always be in the forward direction, that is towards the fetal heart, and to forward direction means it should be always above the baseline. Okay, so there are these three triphasic wave patterns like this. Okay, so three peaks are there, and mind you they are not below this baseline. Okay, S is the highest wave, that is for fetal ventricular systolic contraction, Next one is the D wave, that is for fetal early ventricular diastole, and A wave is for the atrial contraction, and it is the lowest point in the waveform. Okay, but still it's in the forward direction, it will be above the level of baseline. Reversal of A wave, that is if it comes below the baseline, it's always abnormal. Okay. So, S, D and A waves, A wave is like approximately less than 10% of the height of the S wave. Okay. So, this is how the normal ductus venosus waveform pattern looks, the like S wave, D wave and A wave. Most important is to look for this A wave, because absence of A wave or its reversal is pathological. Okay. So, as I have said that in the first trimester, if there is absent or reversal of A wave, it predicts like there are chances of aneuploidy and there can be congenital heart defects. Okay. So, what we have to do is, like, for aneuploidy, it can be like trisomy 21, 18 and 13. Okay, and cardiac function, some major congenital heart diseases can be associated. Okay, but mind you, sometimes there can be this isolated finding of absent or reversal of A wave. These are like normal in many patients, and to rule out cardiac heart diseases, congenital heart diseases, the patient should undergo fetal echo also. Okay. But for this aneuploidy thing, this A wave absence or reversal should be used in conjunction with the nasal translucency, nasal bone and tricuspid regurgitation. Just isolated reversal or absent of A wave cannot show, like, tell you yes there is aneuploidy. There should be some other markers also, like increased NT or absent NB. Okay. So, in the first trimester, this is the role of ductus venosus for aneuploidy and for congenital heart diseases. For heart diseases, fetal echo should be done, and for like aneuploidy, there should be some other soft markers also, NT, NB, tricuspid regurgitation. So, all these should be like measured. Okay. So, so this absence or reversal of A wave should be taken like seriously. Okay. In the second trimester, this absent or reversal of A wave is a strong predictor of stillbirth. Okay. We all know that while doing the Doppler in the second and third trimester, the first Doppler that like becomes abnormal is umbilical artery. That is, for example, placental resistance is increased, and now the umbilical artery shows absent or reversal of the end diastolic flow. These are the findings of like IUGR. Umbilical artery shows this abnormalities. The end diastolic flow is reduced, or end diastolic flow is absent, or end diastolic flow is like reversed. Okay, but this ductus venosus is the waveform pattern that is last to change in IUGR. Okay. I'll discuss this later in this video. Let's first discuss the normal waveform patterns. So, ideally, like the sample volume should be small. Okay, and like 0.5 to 1 mm, and the waveform pattern should be very clear, SD and A wave. Make sure that it doesn't get like intermixed with the adjacent veins or arteries. For example, like hepatic artery, portal vein, hepatic veins, it should not be intermixed with these. Like here there is superimposed waveform pattern of artery also, here the superimposed waveform pattern of portal vein also. So, to make sure that the pulse Doppler sampling is done at the site of aliasing. Okay, at the site of aliasing, and that should not be like much towards the IVC. It should be at the site of aliasing, and the sample volume should be small, and insunation angle should be like less than equal to 30 degree. Okay, so in the first image actually I have shown the correct sample volume and proper cursor location in the ductus venosus at the site of aliasing. So here see, the sample volume is at the site of aliasing, and like not much towards the IVC end of the ductus venosus. But in this second image, this sampling is done like at this site closer towards the IVC and not at the site of aliasing. So there is this superimposed waveform pattern of adjacent vessels. Okay, and this superimposed like Doppler pattern of adjacent vessels can be mistaken for reversed flow in the A wave. Okay, so the cursor placement is like very important also. Okay, and in like in the third case, the sample volume is just so large that there is simultaneous sampling of the portal vein and the ductus venosus. Okay, so sample volume, that gate is very important. It should be small, 0.5 to 1 mm, otherwise there will be simultaneous sampling of the adjacent vessels. And also where you place that sample is very important. It should be at the like at the site of aliasing, not towards the heart or towards the IVC end. Okay, so cursor placement is very important. So this is how the normal waveform pattern looks, the S wave, the D wave, and this A wave. Okay, and this is how the abnormal, this reversal of A wave looks like. Okay, so it can be done in sagittal images also, this sagittal, or it can be done on axial images also. In the early trimester scans, sagittal view ductus venosus is very well visualized, but in the second and third trimester, sagittal as well as axial scanning can be done for ductus venosus. Okay, so as I have said that in the first trimester, it's for aneuploidy and congenital heart diseases. In the second trimester, it is for the cardiac impairment. Okay, and this cardiac impairment can be like in any case, like fetal growth restriction, like Rh negative pregnancies because of the anemia, in cases of hydrops, in cases of twin transfusion syndrome. So in all these case scenarios, ductus venosus Doppler comes into play. Like in the early scan, aneuploidy risk stratification is done along with the NT, NV and tricuspid regurgitation. FGR, IUGR, the clinical scenario answered A, when to deliver. For example, I will give you a case scenario like there is this patient of 28 weeks, like early onset IUGR is there, less than like 28 weeks pregnancy, and there is IUGR. Now you want to like, and the umbilical artery is showing absence or end diastolic flow reversal. Okay, the guideline says after the reversal of end diastolic flow in umbilical artery, you have to like deliver immediately, but it's too early, it's just 28 weeks. Now you want to stretch the pregnancy, for example, up to some weeks so that lungs develop, you give steroids. So now the Doppler which becomes important is the ductus venosus. Okay, you take the patient for regular like biophysical profiling, and cardiotopography is done, steroids are given. Okay, and also ductus venosus Doppler is done. Ductus venosus, I have said, is the last one to show the changes. If the ductus venosus is normal, you can still stretch the pregnancy, but if ductus venosus becomes abnormal, like A wave reversal is there is nothing can be done, and you have to like immediately deliver the patient. Okay, so in IUGR patients, ductus venosus Doppler tells you like when to deliver. Okay, Next is the Rh negative pregnancies, because in the Rh negative pregnancies there are risk of this fetal anemia, okay, and this can be like ascertained by the PSV of the middle cerebral artery Doppler, and also important is the Ductus Venosus Doppler, because it tells you about the effects of the anemia on the heart, whether heart is in the process of heart failure is there, okay. So for patients of Rh negative pregnancies, anemia is there, and due to anemia what's the risk for cardiac failure, this is given by the Ductus Venosus Doppler. Same in the hydrops also, and same in the twin transfusion syndrome also. In the recipient patient there is very much increased preload for the heart, and again same situation, cardiac strain can be ascertained by the Ductus Venosus, and so is the role of Ductus Venosus Doppler in all these situations of early pregnancy in IUGR. Okay, like Ductus Venosus Doppler is late but critical marker, okay. It tells you about the time of the delivery, especially in early onset IUGR, like less than 32 weeks. Next is the Rh isoimmunization and fetal anemia. Fetal MCA PSV is used to detect the anemia, and then Ductus Venosus Doppler evaluates that whether that anemia has progressed to cardiovascular compromise or not, and all these like are indicated by the absence or the reversal of the A wave, okay. Next is the hydrops fetalis. So Ductus Venosus Doppler reflects the elevated right atrial pressure, poor cardiac compliance, okay. And in the twin to transfusion syndrome, Ductus Venosus Doppler helps to identify the cardiac strain in the recipient twin and severity, staging and prognosis, okay. So this A wave reversal signifies the myocardial dysfunction, rising central venous pressure, the impending fetal acidosis and poor fetal outcome, okay. So the cardiac status and the acid base status of the fetus is like can be determined by this Ductus Venosus Doppler, and that in that too particularly from the A wave, okay. So there is role of Ductus Venosus pulsatility index. So if it is above the 95th percentile, it indicates increasing fetal cardiac stress, okay. And it doesn't tell you about the placental resistance, it tells you about the fetal cardiac stress, okay. So the PI is normal, there is this forward A wave above the baseline, the fetus is compensated, and continue the surveillance. If the PI is raised, it denotes like early cardiac strain is there, and you should increase the monitoring of the patient. If the A wave is absent, there is severe compromise and prepare for delivery. And if there is reversal of the A wave, then it is pre-terminal and urgent delivery is required, okay. So at the end, if I say that Ductus Venosus Doppler assesses the fetal cardiac function and the central venous pressure, and that abnormal or reversed A wave indicates fetal decompensation, and it's very crucial in timing the delivery in growth restriction, anemia, hydrops and twin transfusion syndrome. Okay, so I think I have done some justice to this topic. In second part of this video, I'll also show you live like how to localize that aliasing on your screens and how to take the waveform patterns, okay. So thank you so much.